Good morning, everybody. Welcome to our TB 101 series. Today kicks off the first session, and we'll be running them every Friday at 10 to 11:15 a.m. Eastern Time from today. So every Friday until sort of mid-September. Um, so we are going to be following the CDC self-study modules initially. A lot of the topics that are highlighted from the modules 1 through 9. And then we have a couple of additional topics thrown in there for testing and treatment of LTBI in children, as well as diagnosis and treatment of TB disease in children, which are not specifically covered in the self-study modules. So really looking forward to sort of providing a general overview of TB. And this series is really geared toward individuals who are sort of new to TB and looking to establish some baseline or foundational knowledge in TB. And we have some other trainings that are sort of next level up. Each week we'll be recording the sessions and we'll be making the recording available so on the same webpage on the website. So every week you will have to register separately for each session, and we've done it that way so that you can choose whichever session you want to join. So even though you registered today, it's not for the entire series. You'll need to register again next week. So we've convened a group of experts from around the region to present on various topics. And today we'll be starting off with an overview of the epidemiology of TB from global and national level. And we will have some time at the end for questions. So I'll go ahead. If there are relevant resources to some of the topics being discussed, we'll be sharing those in the chat. And our health educators, Shweta Suresh Kumar and Priscilla Morera, will be running the sessions. So if you all have any questions, feel free to email them. They can share their information in the chat as well. Each session will have an evaluation link for each session. If you have any comments, any suggestions for improvement, we really welcome your feedback. I want to hear whether or not the information is useful for you. So that's sort of a brief overview, and I'll go ahead and introduce our presenter for this morning, who is Dr. Edward Zurowesti. Dr. Zurowesti is a trained in family medicine. He is the founding medical director for the Migrant Clinicians Network. He's also the staff physician at 7 county health department clinics in Pennsylvania, and he's the TB medical consultant for the state of Pennsylvania with the Department of Health. He's also been very active with the Stop TB USA, the National TB Controllers Association, and the TB Elimination Alliance. And he's a frequent faculty at a lot of our trainings. So he's going to present to you on the EPI, and I'll turn it over to you, Dr. Zurowesti. Thank you.
All right. Thank you very much, Anita. And welcome, everyone. I know you've taken a lot of your valuable time today to listen to this presentation, so I really appreciate it. I know how busy all of you are out doing your real jobs. I want to make this as informal as possible as you can with a remote presentation like this. So if you have any questions as we go along, any need for clarification, just put it in the chat or just unmute yourself and just ask me. I'm happy to answer as we go along. I'm going to ask some questions also that I want you to respond to in the chat as we go along, also to try to get some feedback from you folks to see what's going on out there in the real world. As Anita mentioned, I'm the TB medical consultant for the Pennsylvania Department of Health, but I actually am the clinician at 8 of our county TB clinics. So I see active TB cases and LTBI cases every month. So I'm going to give you my perspective. The title of this session is Overview of Global National Epidemiology 2024. I have nothing to disclose or disclaim, except I will claim that I did take this picture of this beautiful woman and her amazing daughter in Guatemala a few years ago. So I will claim that. I want to start off with a quote from William Osler in 1904, which is 120 years ago. And William Osler from Hopkins said that tuberculosis is a social problem with a medical aspect. And that's true today. Whenever you see high incidence of TB around the world, there are social economic problems that are occurring in that population to make TB at high risk. And when you see pockets of TB in the United States, again, there are socioeconomic reasons for this to occur. This is a totally treatable and curable disease that still plagues the world. I'm just going to start off to make sure we're all on the same page. As we all know, TB is an airborne pathogen. The only way you can get TB, except in very, very rare cases, is through the air. So somebody with pulmonary TB coughs, and when they cough, millions of those bacteria float in the air, then you breathe those into your lungs, and your body initially fights it off so you don't get sick. But the body doesn't have the ability to kill all the bacteria because some of the bacteria go into a protective shield, a protective coating, and go dormant in your lungs. And that TB can stay dormant 10 years, 20 years, 50 years. And on average, with a good immune system, a person has about a 10% risk of that TB reactivating and causing the active disease of TB in their lifetime. 90% of people who get infected with TB will never get active TB. Anything that affects your immune system will make, sorry. Sorry, folks. Please mute your phone so this doesn't occur. I'm going to mute my phone right now. All right. So as I said, about 10% of people will go on to active disease. About 5% of that is in the first 2 years after you're infected. And untreated, on average, a person with TB will infect 10 to 15 other people before the diagnosis is made. So you don't have to know the person, you don't have to touch the person, you just have to share the airspace with that person with active TB. And you don't even have to share the airspace at the same time. If somebody is very contagious and they cough in a closed space and they leave that closed space and you come in that closed space an hour or two later, you can still get infected. Well, this disease has been around forever. The earliest evidence of TB comes from skull fragments that were actually found to be the first specimen of Homo erectus to be discovered in Turkey. The skull fragments bore small lesions that were an indicator of TB, and recent efforts to date that specimen suggest that it's more than 1 million years old. So TB has been around since the beginning of time, since man. But the variant that kills humans today, the Mycobacterium tuberculosis, MTB, emerged about 2,000 years ago. And it emerged when people were living in denser settlements along domesticated animals. And oftentimes those domesticated animals were the reservoirs for the TB. Let's just go back through history a little bit. In the 17th and 18th century, TB took 1 in every 5 adult lives. 20% of people who died during those centuries died of TB. And just from 1700 to 1900, 1 billion human beings on the planet died of tuberculosis. And it wasn't until 1882 that Robert Koch discovered what actually caused TB, and that was the TB bacillus. But we still had no treatment. From 1873 to 1945, the only treatment we had for TB was sanatoriums. And there was all kinds of treatment that was done in sanatoriums. We collapsed lungs, we removed lungs or removed partial lungs. And we did a lot of nutritional treatment and fresh air. A lot of these sanatoriums were up in the top of mountains where people actually spent most of their time outside, even in the wintertime. And about 50% of people who went to sanatoriums died of TB, but 50% of people at that time even survived. So it still was a huge killer, but there was some success with the sanatoriums. It wasn't until 1944, though, that we developed the first antibiotic, which was streptomycin. And initially, we thought it was the golden pill. We thought it was going to cure all TB. We started giving streptomycin, and people started to improve greatly. But within a very short period of time, this is a very smart bug, and it became resistant to streptomycin. Then in 1952, we added isoniazid. So we thought, oh, here we go. We've got these two drugs. We'll use them together and we'll cure TB. But again, very quickly, the TB bug became resistant to both isoniazid and streptomycin. So it wasn't really until 1965 with the development of rifampin, and it really wasn't approved into the United States until 1971 that we finally had a cure for TB. So we had no medical cure for TB until 1971. And that seems like it was a long time ago, but it really wasn't that long ago historically. I mean, that was the year I graduated from college. So I'm old, but I'm not that old. Uh, so it wasn't until 1971 that we had an absolute cure, but we can now cure TB. No one should be dying of TB in 2024. But in fact, a little over 10 million people um, get active TB every year in the world, and about 1.6 million people die a year of TB. 1.6 million people died last year of tuberculosis. About 12% of the infected people are co-infected with HIV, and about a third of those people will die of TB. It's estimated that we have a little over 550,000 cases of multiple drug-resistant TB, but this is a very low estimate because many parts of the world do not do drug susceptibility testing. It's also estimated now, we have a little over 8 billion people on the planet now, and it's estimated that about 2 billion human beings, 1 out of every 4 human beings on the planet, are infected with TB and have that 10% risk of going on to active disease in their life if their immune system is good. TB causes more deaths among women than all causes of the maternal mortality. Every day, as I mentioned, 20,000 people develop TB, and every day, 4,400 people die in the world of TB. 4,400 people died yesterday, 4,400 people will die today, and 4,400 people will die tomorrow of a treatable, curable disease. It's a disaster that we still have this problem in the world. And just to kind of put that in perspective, and I did spend some time in West Africa working on the Ebola epidemic. If you ask most people, are you more afraid of Ebola or tuberculosis? A lot of people are more frightened of Ebola, but in fact, in all the Ebola outbreaks, less than 14,000 people have died of Ebola. That's less than 4 days of TB deaths from Ebola. Every year, as I mentioned, 10 million people around the world become sick with TB disease, and on average, a person dies every 15 seconds of tuberculosis. TB still accounts for 1/4 of all preventable adult deaths in developing countries. So it's still a problem in the world. In the United States, people have oftentimes forgotten about this disease, but I'll show you why it's still important to think about TB in the United States. As I mentioned, on the planet, 1 in every 4 human beings currently living have TB infection. And since we've been able to cure TB since 1971, now it's estimated that 1 in 50 individuals living in the world have been cured of active TB. 1 in 50 people that you're going to meet have been cured of TB, TB disease, which is a pretty amazing statistic. It's a very, very common disease. About 1/3 of the 33 million people in the world who are living with HIV/AIDS are co-infected with TB, or about 10 million people are co-infected with TB and HIV. And without treatment for both HIV and TB, 90% of those individuals will die within months. You know, I mentioned that if you have a normal immune system, your risk of reactivating TB if you're infected is 10%. But if you have untreated HIV with a very low CD4 count and a high viral load, your risk is not 10% in your lifetime. It's 7 to 10% per year of going on to active disease. TB is actually the leading cause of death among HIV positive people. So that when you hear people dying of HIV, about 50% of the time, what actually kills them in the end is tuberculosis. When we look at the difference between men and women, on this graph, the purple is women, the green is men. Men have much higher incidence of TB than women at every age group except the 15 to 24 age group, where women are a little bit higher than men, and the 5 to 14 age group, where women are a little bit higher than men. Otherwise, men have much higher incidence of TB than women do. And there's a lot of questions of why that is. But it's felt that it's because of more exposure and more time out in the world than sometimes with women. When we look at, you know, we used to say we only needed to test people who had been in our country, were born in a country of high incidence of TB. We only need to test those people that were recent immigrants to the United States within 5 years. But if you look at this graph, it's all over the board. In reality, less than 40% of the active TB cases are in individuals who came to this country less than 10 years ago, whereas another 34% of people that present with active TB have actually lived in the country for over 20 years. 34% of the people who present with new active case of TB have actually lived in the United States for over 20 years. So this tells us that we need to screen all individuals from high-risk countries, no matter how long they've been in the United States. Well, I want to talk a little bit about some recent situations with panels physician screening. And to start this discussion, I want to talk about the difference between migrants, refugees, asylum seekers, and undocumented immigrants. A lot of people just lump those all into migrants, but what the definition of migrants is that these are individuals who have moved from their home country or have migrated within their country for various reasons, either for work, for family reasons, for fear, for war, and now we're seeing a lot more because of climate. We're seeing a lot of climate migrants who are coming to the United States because of climate change in their countries. A refugee is somebody who has applied to become a citizen in the United States, are in refugee camps all over the world, and are then screened by some of these panel physicians before they are allowed to come into the United States. Asylum seekers are people who end up coming across the border, end up on U.S. land, and apply for asylum because of fear or reprisal if they return to their home country. So those asylum seekers are in the United States illegally, have gone through a process, and are awaiting legal asylum attorneys to come before a judge to apply for asylum. Undocumented immigrants are people who come under the radar into the United States and do not seek asylum and are coming into the country. As of October 1st of this year, 2024, the following changes will be instituted for individuals who will be coming to the U.S. as refugees. So this is only related to those refugees, not migrants, not asylum seekers, not undocumented immigrants. For anyone who is coming in as a refugee, the panel physicians now, all individuals over 2 years of age, will have an IGRA done before coming to the US. We didn't used to do that before people came in. And if they have a positive IGRA, then they'll have a chest x-ray to rule out active disease. If they don't have active disease, they're not going to be offering any LTBI treatment. So these individuals will come into the United States as refugees, and they will come, they'll come and there'll be a list of those individuals, EDNs for those individuals that will come to your health departments. And then you'll need to offer them LTBI treatment. All individuals 15 years of age and older will have a chest x-ray before coming to the United States. And if that's abnormal, they'll have 3 sputums for smear and culture. And if that's positive, they'll need to be treated completely for active TB before coming to the United States. So those are some of the changes that are occurring this October in the panel physician screening of refugees. Well, who do not have to be screened at all before coming into the United States? Student visa holders are not required federally to have screening for TB before entering the United States. Many colleges and universities have policies where they will screen individuals who come from high-risk countries before they're allowed to matriculate in the colleges or universities, but it's not a federal mandate. Temporary work visa holders are also not required to be screened for TB. The millions and millions of tourists who come across into the United States every year are not screened for TB. And many of them are LTBI or could have active TB. We don't know. We don't screen. Diplomats are not screened, and obviously undocumented individuals are not screened. This is important because I've told you about how prevalent TB is in the world. We will never be able to stop active TB coming into the United States because of these millions of people who are coming in not screened for TB. So we need to know what's going on in the world TB-wise. We need to eliminate TB from the world if we're considering at all eliminating TB from the United States. So TB anywhere is TB everywhere. The other people that no longer need to have yearly TB testing are all of you. In a report that came out and recommendations that came out from the National TB Controllers Association and the CDC in 2019, it said that in the absence of known exposure or evidence of ongoing TB transmission, U.S. healthcare personnel without LTBI should not undergo routine serial TB screening or testing at any interval after a baseline. So everybody should have a baseline TB screening, but after that, unless they're exposed to an active case, they no longer have to have annual screening. And the reason for that was, of that screening, almost all of the positives were false positives. This is a low-risk group of people. Even somebody from Bellevue Hospital in New York City is more likely to get exposed to TB on the streets of New York City than they are in Bellevue Hospital as a nurse. I'm going to give you a bunch of data and a bunch of statistics, and I always throw this slide up. This is a very young Ed Zerwesti at a sign outside of Gold Hill, Colorado. And this sign is statistics, it's data, but it says it was established in 1859, elevation 8,463 feet, population 118, total 10,440. So that's statistics and that's data, but that's not good statistics. So what I'm going to give you now is some more good data. Well, first of all, where we are as one of the leading cause of deaths in the world. As I said, TB used to be at the very top as the leading cause of death. But now we were down to number 13, but now we've actually creeped up to number 10. We're right under diabetes now as we're the 10th leading cause of death in the world. And it's the number one infectious disease cause of death. There are diarrheal diseases that you actually die of dehydration and that sort of thing. But tuberculosis is the leading cause of infectious disease death. Now, there have been periods of time where HIV surpassed us and COVID surpassed us for a couple of years, but we're back to being number one infectious disease cause of death in the world. Yay, TB. Well, now let's talk about TB in the United States. Well, in if you look back in the early 80s, it looked like we were going to eliminate TB. Look at this. It was coming a very straight line down. It looked like by the year 2000, we were going to eliminate TB in the United States. So guess what happened right here? Happened right here was Congress decided, the CDC decided, we no longer need to fund TB. There was a real decrease in public health. Right about this time also, this new kid on the block came in, HIV, and we started seeing a lot of HIV infected individuals. And all of a sudden we had a big resurgence of TB that peaked in 1992 with over 26,000 cases. This is what Lee Reichman has dubbed the U-shaped curve of concern, where your concern goes down because you're eliminating something, and then all of a sudden there's a resurgence of the disease. And that's what happened in New York City alone. It took $1 billion to curb this big increase in TB. A lot of this was multiple drug resistant TB. We started doing directly observed therapy around the same time and started really being conscientious about following active TB cases. So then again, we started seeing a steep decline. And again, it looked like, here we go, we're going to eliminate TB by maybe 2010 now. But then it started plateauing out in these years, and it's become a big concern again. TB, the CDC has level funded TB for over 30 years now. For the last 30 years, there's been no increased funding from the CDC in TB. And that's because there's been no increased funding to the CDC in the last 30 years. So look what's happened. We had a really drop about 20% right at COVID. From 2019 to 2020, there was a big decrease, but now we come roaring back till in 2023, last year, we had 9,615 cases, which was a 16% increase just from 2022. And I'm going to go into that in a little more detail. So TB is coming back, and that's a big concern to many of us. Here's another way to look at it. The dark is people who were born outside the United States, and the light bar is people born inside the United States. And you'll see we had this big decrease from 2019 to 2020 during COVID, but then it gradually came up over the next 2 years. And then this year, it has gone up even past pre-pandemic. We're now right about and a little above the 2013 statistic with that 9,600 cases recorded in 2023. So, you say 9,615 cases. That doesn't sound like a lot of cases to be concerned about, but that's really the tip of the iceberg because we have to do contact investigations. And when we do contact investigation, since this is an airborne infectious disease, we end up interviewing about 18 individuals per active case. When we do that, we end up finding about 1% of the time, we find another active case. About 20% of the time, we find LTBI, people that have been infected from that individual. So we end up having to deal with about 172,000 cases from that 9,600 cases. Those people need to be evaluated, tested, and if positive, offered preventive treatment. It's estimated now, I told you that about 2 billion people on the planet are infected with TB, and of those, about 13 million are in the United States. So that's our pool that we're getting these active cases from. About 10% of those individuals, on average, will go on to active disease sometime in their lifetime. So this is the pool that we're dealing with. Here's another way of looking at TB. Again, the pink is US born, the blue is individuals born outside the United States. And in the early 90s, about 75% of the active cases of TB in the US were people born in the US. Those were people who were born during those high endemic years before we had treatment of TB. Only about 25 to 30% were born outside the United States. But look what's happened over the last 30 or 40 years. We've had a reverse of that. Till now, 76% in 2023, 76% of the active TB cases were in people who were born outside the United States, and only 24% were people who were US born. So we've seen a big increase, even though only about 12% of the individuals in the United States, 12% of our population were born outside the United States. But that 12% of our population has 76% of the TB burden. 12% of the population has 76% of the TB burden. So TB now is in pockets in the United States. We know now that we need to put the majority of our efforts of screening and treating of TB infection in the population at highest risk, which are those individuals from high-risk countries where TB is a much higher burden, and those individuals have a much higher incidence of TB infection. Here's another way to look at what happened during COVID. So if you look at the middle here, from 2019 to 2020, we saw a 20% decrease. But then right the next year, 20 to 21, we saw a 9% increase. It went up 9%. 21 to 22, another 6% increase. And just last year, from 22 to 23, we saw a 16% increase of TB in the United States, which puts us now at a 2.9 per 100,000 incidents of tuberculosis in the United States, or 9,615 cases. I want to stop right now and just kind of poll the audience, because what we're seeing in Pennsylvania, we're seeing numbers already in the first quarter that are surpassing what we saw in 2023. So it looks like we're going to have another increase this year, 2024, over that very high incidence in 2023. So I'm just wondering if people will put in the chat, or if people can unmute and tell me if you're now seeing in your clinics a higher incidence this year, 2024, than you did even in 2023. Just shout it out or put it in the chat for me and let me know. I have to tell you, in my clinic alone in Harrisburg, Pennsylvania, this one county. I currently have I just had another new case yesterday of active TB. I'm up to 13 or 14 active cases in that one clinic. Usually I have 6 to 7 active cases routinely in that clinic. So I'm about twice as much as normal right now. I have 3 ocular cases in that one clinic alone. Would anybody like to tell me what's happening in your area? Just unmute and let me know. Or let me see if there's anything in the chat. Let's see. Most definitely an increase. They are sicker than in the past. That came from, let's see, I'm not sure where that came from. Same here. We have 0 to 1 active cases so far in 2024. We already have 5 active cases, most definitely an increase. They're sicker than in the past. In Virginia, we're seeing the highest 4 active 40 diagnosed LTBI. Yes, I believe so. Newcomer Health Program, higher in the past. Virginia's as a whole is up. Northern Virginia. Yeah, so it sounds like you're all seeing more also. Okay. Well, that's my feeling. So it's going to be interesting. Um, and again, I think last year it might have come a little bit on the radar of Congress that TV's coming up. Um, but I think if we have another big jump this year and we get back to going in the opposite direction, we've gradually, even with not going down much. We are going down about 1% a year. We are averaging going down about 1% a year over the last several years. And now going increase, if we have 2 years in a row with a significant increase, I think that may get the eye of Congress. All right, let's move on here. So overall, the US saw an increase of 16% from 2023, and that wasn't evenly distributed. We saw an 18% increase in the foreign born and only a 9% increase in the US born. So that discrepancy, that disparity has continued and actually widened so that we had a much higher incidence. As I said, 76% came from the foreign born, people born outside the United States, and only 24% US born. But the East Coast, where we all are, saw almost 25% increase. Pennsylvania, we saw a 25% increase from 22 to 23. It was interesting to me that Texas only saw a 12% increase, which was lower than the national average, and Florida saw an increase right at the national average. Now, why was that, do you think? Well, I think if we all remember, hundreds, thousands, actually thousands of people were bused or flown from both Texas and Florida to the East Coast. These were asylum seekers who came across, and many of the asylum seekers, for example, from Haiti and from Venezuela, very high incidence of TB. So that I think that has a significant increase on the East Coast of what we're seeing, because we're seeing a lot of our communities that have welcomed these refugees, these asylum seekers, and many of them have gone on to have active TB. We have to be very, very careful about talking about this, because there's already a segment of our political population who are blaming refugees, immigrants, and asylum seekers for being drug smugglers and rapists and insane. And we don't want them to also be labeled as bringing diseases like tuberculosis to the United States. But that is really the fact that's happening. Obviously, it is not their fault. As we all know, the reason somebody gets TB is because they forgot and started to breathe. The problem is that if you're a human being and you're breathing, then you're at risk of getting tuberculosis. That's your fault. Here's another breakdown of the East Coast. You can pick out your state. There was a lot of people that talked about Virginia there, and we don't have Virginia in our catchment area. But if you look at the East Coast, the highest was the District of Columbia. It had a 73% increase. The only state that went down at all was Connecticut, and it only went down one person, went down 1%. Vermont stayed the same at 3, but almost everything else, everybody else went up. Maine went up 52%. As I said, Pennsylvania, we went up 25%. New York went up 26%. New Hampshire went up 27%. Michigan went up 24%. Massachusetts went up 45%. Overall, the East Coast, this is the Global TB Institute's catchment area, went up almost 25%. And again, it is in people that were born outside the United States because that's where they got infected, and now they're reactivating their TB. I'm throwing this in just because I get tired of these statistics sometimes, and I need to throw this in. I think it's, somebody obviously was very unhappy the next morning when they came to see this. It's pretty funny. I'm just hoping that turtle was not a female and decided that this looked like a beach and was going to bury her eggs there. I think she could have dug down and buried her eggs, but I think a few months later, when those little eggs were hatching, it would have been very difficult to come back to the surface. So hopefully that didn't happen. Now we're going to talk a little bit about Pennsylvania because that's where I work. This is a picture actually of a TB clinic back in the 20s. TB, I don't look like that anymore. I don't wear that white coat and I don't have that thing in my head, looking at this little kid's throat. But our TB statistics in Pennsylvania, in 2023, we were up to 215 cases. 75 of those cases were in Philadelphia, and the other 140 were the rest of the state. And that put us back to 2012 numbers. So we've gone backwards, as I mentioned before. The good news is we're not seeing much in the pediatric population, and that's because we've really decreased transmission. We're doing a good job of contact investigation and diagnosing those kids really quickly and getting them on TB treatment for LTBI so that they don't go into active disease. It was worrisome last year, though, because if you'll notice, in 2018, we had no pediatric cases. In 2019, we had one. 2020, we had one. In 2021, we had none. We had 3 in 2022, and we had 6 in 2023. So that's very worrisome to us in Pennsylvania that not only are our active cases going up, but our pediatric cases are going up. The good news is the majority of those were in the older kids. 5 of those were in the 11 to 15 age, and there was only 1 under 5. So that made us feel a little bit better. But this is a worrisome trend. That's why we look at statistics. We are going in the wrong direction in the United States, and that's a very concerning thing to me and should be for all of us. How about deaths in the United States? The good news is very few people die in the United States. Many people are diagnosed of TB at their death in the United States. These are older people oftentimes that die, and they're not diagnosed of TB until they actually have died. In 2020, we had 600 deaths. We've been averaging about 500 to 600 deaths a year in the United States out of those 8,000 or 9,000 cases. So it's not a very high mortality rate, but it's still very worrisome. No individual should die of TB. This is a treatable, curable, preventable infectious disease. We know how to treat it. We know how to prevent it. We just don't have the political willpower and the funding to do what needs to be done, either in the United States or in the world. It's a disgrace that we're still plagued by this ancient disease. How about where is TB? Well, almost 80% of TB is in the lungs, and that's where it's transmitted. But about 21% are extrapulmonary. The leading is lymphatic. We see a lot of cervical lymphadenopathy, TB. There's also pleural TB, bone and joint is very common, peritoneal is very common. It can be anywhere in the body. As I said, we're starting to see a lot more ocular TB. I think it's because the ophthalmologists are doing a much better job of diagnosing active TB in the eye. But it can be anywhere. TB, infertility, TB is the leading cause of infertility in women in India. I'll say that again. TB, active tuberculosis, is the leading cause of infertility in women in India because of the infection in the fallopian tubes. It's very, very common there. So it can be anywhere in the body. We used to say if you understand syphilis, then you understand medicine. And it's really the same with TB. If you understand TB and really do a lot of work in TB, you find it anywhere in the body. It makes you learn a lot about the rest of the human body if you are an expert in TB. I put this up, as I mentioned, we're starting to see TB in pockets. And if you look at the right-hand side here, if you look at the race and ethnicity, the Asian population, over a third of all the active cases in the United States are in the Asian population. That's why the TB Elimination Alliance, which is an alliance between Stop TB USA, APCHO, which is the Asian Pacific Islander Community Health Organization, and Hepatitis B Coalition, got together several years ago to focus their efforts on education and screening of the Asian Pacific Islander population in the United States. If your community, the individuals that are in your catchment area are of this population, the Asian Pacific Islander population, they are at the highest risk of active TB in the country. 30%, 36% of all active cases of TB in the United States come from the Asian population. Closely behind them is the Hispanic Latino population. So these are the groups of people that we want to put our time and effort and funding into screening for TB infection and treating for TB infection so they do not go on to active disease. Followed closely by the African American population. So this is the group of individuals who are at highest risk, should be our highest priority. If we have $1 to spend on TB screening, it should first of all be on contacts of active cases, because those individuals have a 5% risk, if positive, of going on to active disease in the next 2 years. And then the next dollar should be spent on these populations and doing mass screenings if possible, or getting other organizations to do that. Educate the Asian population, nonprofit organizations, community health centers that provide care for this population, and have them screen and treat them in their clinics. This is a slide that tells us about the cases that are coming either from recent transmission. In other words, you have somebody with active TB, they're coughing in their household, they infect a child and the child goes on to active TB very quickly. Those would be recent transmissions. The people that are just reactivating their old TB, and it could have been they got infected 30, 40 years ago. 88% of our cases are in reactivation of the latent TB infection, reactivation of somebody who's already infected. Only 12% are recent transmissions. Um, so that, and this is what we need to continually try to make less and less by doing as soon as possible contact investigation, finding those people that are infected and getting them on preventive treatment as soon as possible. So in summary, and we're going to have plenty of time for some questions at the end here. Globally, TB incidence rates have declined only gradually over the past 20 years. The COVID-19 pandemic set back TB control efforts sharply in 2020 and led actually to an increase of TB mortality globally for the first time in many years. The TB rates in the United States, after 27 years of declining, we had 27 straight years of declining TB cases. The number of TB cases declined considerably in 2020 to only 7,171 cases, but that was a very factitious decrease because it just coincided with the COVID-19 pandemic and people were just not coming in. The TB counts and rates increased in 2021 and 2022, but now they've rebounded to pre-pandemic levels, much more in 2023, going up to 9,165 cases, which we have returned us to the 2013 levels. And as I mentioned, and just polling you folks, it looks like that trend is going to continue, that 2024 will show another increase. And if we have 2 years in a row, that's starting to be a trend. And that is a very worrisome trend. That means that we're not getting a handle on TB, that it's starting to get ahead of us again. Again, non-US born persons account for the majority of cases, 76% of the cases in 2023 of active TB were in people born outside the United States, and almost 85% of cases in this segment population are due to reactivation and not community transmission. So I think we're going to end there. That's my contact information. Feel free to call me or email me at my email address there. Be happy to talk with any of you. And I'm sure these slides are going to be available to all of you in the future. You'll notice the children always go for the largest, shiniest object in front of them. That's why the kid is grabbing my nose. All right, let's go to some questions. Anita, have you guys been gathering the questions? Do you have any questions for me?
Dr. Z, I don't see any questions. Participants can unmute or type your questions in the chat. We still have
There, I
30
see
minutes left.
one question. It says, one problem we run into is getting the LTBI patients to take medication for treatment. Yeah, that's a very common issue. So when you have somebody who's infected with TB, who is asymptomatic, they've got a normal chest x-ray, to convince them to take medication that have side effects is a difficult proposition. It's very hard for somebody who feels fine to take any medicine. So I think it really has a lot to do with how you present it to them. My technique is I present it to them as, if you go on to active disease, you're going to infect 10 to 15 other people before we diagnose you with active disease. We'll be able to cure you of active disease, but we'll have to treat you for at least 6 months for active disease with a lot more pills. And by the time we diagnose you, you're going to infect 10 to 15 people. And those 10 to 15 people are your family, your children, your friends, your coworkers. So I don't think you want that to happen. So not only are we going to save you from having the disease, but we're going to protect you, your family, and your friends. And oftentimes when I present it like that, people are more likely to put up with the side effects. The other thing is make sure you're using the shorter regimens. Make sure you're using either the 4 months of rifampin or the 3 months of weekly high-dose rifapentine and INH. There's a much greater chance that they're going to complete those. 3-HP, the INH rifapentine, 12 weekly doses. In Pennsylvania, 94% of our patients complete that treatment. The 4 months of rifampin daily, 88% of our patients complete that treatment. So it's very effective. But that's a good question, and it's a problem. And so it has a lot to do with how your clinicians and your nurses are offering that treatment. If you spend a lot of time on worries about side effects and hepatotoxicity and that sort of thing, then you get a lot fewer people who want to take it.
Dr. Zerwest, there's another question by Kristen Green. Are
Yeah,
there statistics for LTBI patients previously treated converting to active?
that's an excellent, excellent, excellent question. We know that the standard of care that we've had throughout the years is 9 months of daily INH. Even if you take 9 months of daily INH, you go from a 10% risk to a 1% risk. Even taking 9 months of INH, you have a 1% risk of going on to active disease. It's not 100%. 5.5% of that risk is in the first 2 years after getting infected. 0.5% of people who take 9 months of INH will go on to active disease in the first 2 years. And that's what we use when we're studying these drug regimens. So, for example, when they did the head-to-head study in 2011 of 9 months of INH versus 12 weekly doses of INH rifapentine, 0.45% of the 9-month INH people got active disease in the first 2 years, essentially 0.5%, which was what was expected. 0.5% of the people who took 9 months of INH got active disease, and actually only 0.27%, or a little over 0.25% of people who took the INH rifapentine went on to active disease in the first 2 years. So the INH rifapentine in the study was found to be non-inferior to the 9 months of INH, but in reality, statistically, it was almost twice as good as the 9 months of INH. So yes, you tell the person your risk goes from 10% to less than 1%. It doesn't go to 0. So you can't tell the person we're absolutely going to prevent you from getting TB. So especially those close contacts, you have to tell them if you have any symptoms of active TB in the next 2 years, make sure you come in right away. This is not 100%. It's about 99%. A little over 99%. Other questions?
Yeah, there's 2 more actually. Christine Sellen, she said, what may be causing the increase in the TB in the eyes?
That is also an excellent, excellent question. And, I really don't have an answer for that. My personal opinion is that ophthalmologists have gotten a good education now, and they because it's a diagnosis pretty much of exclusion. They rule out all the other things that cause, the most common thing is a uveitis. And so they rule out the most common thing that causes uveitis. And there are a multitude of things that do that, like toxoplasmosis and histoplasmosis. A lot of things can cause that. They rule all those things out. If the person has a positive IGRA, then they send them to us. And then the interesting thing is we start treatment, and guess what? The person's eyes, and some of these people come to us almost blind. Sometimes it's just in one eye. And rapidly, with treatment of the TB, and also oftentimes they use steroids because there's an inflammatory process also caused by the bacteria. So they have to use steroids, either eye drops or oral steroids at the same time. But we see miraculous improvement of the person's vision in a very short period of time. And we see changes in the eye of curing the uveitis. Sometimes there's even little nodules that they see that resolve. So the ophthalmologist working closely with us can see direct changes and cure of the TB. And we cure it within 6 months of TB treatment. So it works, because it's very difficult. It's really not worth it to put a needle in the eyeball and try to extract fluid to get a culture, because it almost never cultures out of the eye. So that I don't encourage people to do that. We just treat them presumptively and then follow them closely with the ophthalmologist. Do you use the 3HR regimen? I use 3HP or 4R. Yeah, that's a very good question also. The 3HR is daily INH and rifampin. And to me, that just puts the person at higher risk of doing daily INH. I would much rather do the 3HP, which is rifapentine and INH weekly, or the 4R, which is daily 4 months of rifampin. I much rather use those two. I don't think I've ever used the 3HR, but it is a recommended CDC regimen that you can use. Any other questions? We still have a couple minutes. If anybody wants to unmute and ask a question, that's certainly okay. Okay, here's another one from Kirsten Green. What are your thoughts on refugee infants, newborns under 1 year of age and cross-reactivity with BCG? We have an increase in young refugees receiving PPDs and high number of in-duration results. That is also superb questions, you guys. Here's what's just come out. It's going to come out. It actually hasn't come out in the 2024 Red Book, the Pediatric Red Book, but it's going to say that you can now use IGRAs in anyone that you would use a PPD on. So most TB experts, pediatric TB experts, now are saying do not place PPDs on anybody that had a BCG, because especially if they recently got their BCG, the chance of them getting an induration is very, very high. And most people are comfortable with the IGRAs in babies under 6 months of age. All bets are off because that child has the immunity of the mother. But above 6 months of age, people are pretty comfortable now with the IGRA results. If the IGRAs are negative, they think that's probably okay.
And I just wanted to add that we do have pediatric sessions coming up in the series, so stay tuned for more information.
Good, perfect. And they'll talk about IGRAs and all that. There's a whole IGRA thing coming up. Yeah. The whole screening for LTBI is another session here that they'll go into all those details. And a lot of people, it's that 9 pills. It's really interesting. We did we did this big CDC WHO project in the Marshall Islands and also in Chuuk in Micronesia recently. And globally, they have a combination pill of INH and rifapentine, so that we didn't have to give 9 pills in Chuuk. We gave 3 pills. 3 pills, because each pill had 300 milligrams of INH and 300 milligrams of rifapentine in the pill, 1 pill. So we gave 3 pills instead of 9 pills, which was tolerated much better. And they weren't any bigger than the rifapentine pills. We're behind in the United States sometimes with these combination pills. Okay. What do you think, Anita and Swata?
I think that's about it. And definitely we have Dr. Zerwesti's contact details. If anybody has any questions, or you can also email me with any questions and I can forward them to Dr. Z. I'd like to thank Dr. Z for his time and for a great presentation. And we look forward to working with you in the future. And also thank you to the audience for coming today and listening to the session. I'm going to leave the evaluation in the chat box, and I can also email them to you. If you could please leave some feedback, or you can also include any questions in there, which I can also forward to Dr. Zerwesti. So thank you, everybody, and we hope you have a great weekend.
All right. Thanks, everybody. Go out and do the good work that you're doing every day. Thanks a lot.